I think he's opening the YouTube so that more children can join there. It's full. It's full. I really appreciate the entire team, JDN and Emerson, the effort that there is nothing you can't do, man.
One of the biggest meeting ever, sir.
Oh, you are all the people heroes.
So National President has joined.
Yeah. And please stream on the YouTube so that other children can join there.
Okay, sir.
And disseminate that information. President, sir.
Yes, sir.
Sir, 1,000 young doctors are awaiting to see you. The participation is full. 80 people are waiting. 100 people are waiting on the line. I have requested your office to stream it on the YouTube so that, more people can see.
Sure.
Hariharan?
Yes, sir.
Hariharan, you can start the proceedings, and Yogesh, you may kindly see that HSG joins.
Okay, sir. Okay, sir.
So,
Go ahead,
good evening.
Hariharan. Yeah, go ahead.
Good evening to one and all present here. It's a great evening, a great beginning for one of those initiatives that IMA continues to fight against TB to NTB. It was March 24th when Robert Cox found out the TB bacteria, and to commemorate it, we have this World TB Day celebrated. And the motto of this day is to end TB. And to make a good beginning, we will start with the IMA prayer by Indranil, who's the convener of JDN. Oh, Indranil.
Thank you, Hari sir.
Yeah.
Thank you, Hari sir. Now I will request everyone to repeat the IMA prayer after me. May everybody be happy.
May everybody be happy.
May everybody be healthy.
May everybody be healthy.
May everybody be free from pain.
May
everybody be free from pain.
May everybody be free from sorrow.
May everybody
Be free from sorrow.
May we be the healing cure
May we be the healing cure.
beyond every greed and lure.
Beyond every
greed and lure.
Thank you very much.
Over to Karan, who's the convener of the subcommittee of IMA NTB initiative for the physician's prayer.
Physician's prayer, not to be repeated. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give singleness of purpose, strength to life, at least a part of the burden of my sufferings, fellow men, and the relation of the rare privilege that is mine. Take from my heart all the guilt and worldliness, that with the simple faith of a child I rely on thee.
Over to convener of MSN, Dr. Ajit, for the flag salutation.
Ajit,
can you unmute yourself?
co-host, is he a co-host? Yogesh?
Otherwise, can Karan continue the flag salutation? It's there on the screen.
Sir, he can join, sir. We can.
Ajit,
Sir, I can speak now.
Ajit, you unmute yourself.
Ajit is a co-host now, sir. Ajit is a co-host. He can speak now.
Am I audible, sir?
Yeah.
Yes, sir,
Yeah,
Ajit, you are
Go
audible.
ahead.
Yeah.
Good
Great.
evening. Sorry for this disturbance. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength. Its course shall be our course. We pledge our allegiance to it and realizing our responsibility as the accredited members. of this national organization. We swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA.
Thank you, Ajit. We would start this program with our immediate past president and the chairman of the NTB initiative, our beloved Ashokan sir, who's leading this fight on the NTB program. And over to you, Ashokan sir, for the welcome address.
Thank you, Hariharan. I'll make it brief. Respected National President, we in the NTB initiative formed by you to bring back Indian Medical Association with the TB map of India to fight. I would just say a couple of points. One is that Indian Medical Association, along with its JDN and MSN, we are present in almost all the districts of the country. You need to see the only other institutions which are present in almost all the districts are only the government as well as the program, national program. So district by district, IMA can match the strength of the government as well as the strength of the. So we are here to fill up the gap in the TB elimination agenda of the Prime Minister so that it becomes a success. I welcome the National President, Secretary General, President-elect, Dr. J.A. Jailal, President of Commonwealth Medical Association, who enabled the credit points, and I'm grateful to the young doctors and students who joined in a number. This program is simultaneously has opened in the YouTube. The links are being provided. So kindly share the information which will be disseminated now to anyone who is not able to enter this room because we have been overwhelmed beyond our capacity. Thank you and welcome all. Go ahead, Hariharan. Yogesh, you have muted him.
1 minute.
Yeah.
Yogesh, echo
Yeah,
both
now-
are lot of echoes.
We welcome our national president, who's leading us from the front to give his presidential address.
Good evening, friends. Yogesh, can you correct it? Lot of echo is coming.
Sir, there is no problem from our side.
Sir, you go ahead, address.
Okay. Good evening. Good evening, friends. This is a important occasion where we are all gathered today for celebrating TB Day. I thank Dr. R.B. Ashokan, past president, sir, and taking the lead in conducting this program, along with JDN and MSN. I think those are the pillars of our Indian Medical Association. I also like to thank here Dr. Professor Jailal for giving he also so much is interested in the TB program and giving us the credit point. As we know, IMA is the forefront in combating TB and has been associated with elimination of TB for long. It has been with the government in all TB programs. And IMA itself has now 2 more MOU signed with Union Against Tuberculosis and Tuberculosis Association of India. And our beloved past president, Dr. R.B. Ashokan, is leading in it. So let's start with the program and see what best we can do from IMA and see if the TB is eliminated. What our Honorable Prime Minister goal in 1930. So I wish all the best for all this program and our further IMA contribution. Thank you.
Thank you very much, sir, for those golden words. Now I invite President-elect Dr. Anil Kumar Nayak, sir, for his address. Dr. Anil, sir, is on the line.
Yes, sir, not had joined yet, sir.
Okay, what about HSG? You can go over to the HSG.
Now, we welcome our beloved HSC ma'am, Dr. Sabari Datta ma'am, who has been helping us, giving us so many permissions to do this. And thank you, ma'am, for all the support. We would like you to address us.
She is not available at sir.
Okay, move ahead, move ahead.
Now we welcome our own J. Jailal sir, the president of Commonwealth Association, who's been helpful in getting those two CPD points as well. Thank you so much, sir, and over to you for the address, sir.
Thank you, Hariharan. Beloved and respected, very fruitful, the National President of Indian Medical Association, Dr. Banusali sir, the leading legend in the TB elimination program, the face of Indian Medical Association in the battle against TB, the Vice President of the Commonwealth Medical Association, our past National President, Dr. R.V. Asogan, the team of young doctors led by the very vibrant leaders of Indian Medical Association, Dr. Abul, Dr. Haran, and all the hosts of the people, and our President-elect and Secretary. I'm indeed extremely delighted, extremely happy today that we are able to organize this program with more than 1,000 delegates on the Zoom and another 1,000 in the YouTube. This shows the fruit of the long tenure of the hard work which is enacted by Dr. R.V. Asokan. Indeed, it is a challenge, it is a duty, and it is the responsibility of every doctor of this country, irrespective of their specialty, to make their fight as this valiant fight with more effectively and patiently and passionately for the elimination of tuberculosis. I'm extremely happy with the theme. The first word says commit. That is what Indian Medical Association is interested to create, the commitment from the doctor community. It is not that just a professional work. It is not just that what we are going to do scientifically, whether we are going to give the tablet, whether we are only going to diagnose, that is immaterial, it comes second. But do we have the commitment to see that Indian Medical Association doctors, we have a responsibility to see our country is coming out of the clutches of tuberculosis. Today, it is very painful to see. We are developed, we have marched ahead in most of the areas, but when the whole world says 25% of the tuberculosis patients are coming from India, is a word which hurts us, the word which stimulates us, which makes us to work hard. And we need to find out ways and means to see to that every citizen of this country is going to get the benefit of our scientific advancements in the tuberculosis, the free nature of providing the drugs to them, and even providing the nutrition to them. All this, the beneficial effort put forth by the scientific community and Honorable Prime Minister, but reach to the people, reach to the doctors. Who else other than the medical doctors of Indian Medical Association can be a connect between the poor man in the society and the top legendary people? And very areas we have, during the time of COVID, we have seen, unless the family doctor is going to say that you take a vaccine, nobody is going to come forward and take a vaccine. The same thing is true for tuberculosis. If the family doctor is committed and say that take this medicine and continuously, and that is not going to be possible. That is why today the Stop TB project of the UN Assembly, the WHO, and Commonwealth Medical Association, we are committed to see the private practitioners, the junior doctors, the family physicians are enrolled or roped into this great battle, so that the ultimate benefit will be able to reach to them. So that commitment, if today's meeting can create into the mind of the youth of our own Indian Medical Association, that is a great achievement we are going to do. And I must professionally and profusely thank Dr. R.V. Asogan being a pillar or icon of producing that passion and commitment and to achieve that goal, and to the mind of every doctor of India, that every one of us has to contribute in this great battle. And I am confident in 2030, with this committed team of work, we can at least say that India is not more a greater contributor, but it is at least we have brought down the death, brought down the other affinity. Then finally, I will say that one thing which we today, yesterday, we had in our own district, what we see that is 30% of tuberculosis is extrapulmonary. That is one area. Again, it changed. No specialist. It's not only pulmonologists. No specialist and no GP can say that it is only belong to the lung, but every part of the body is involved. So every member of Indian Medical Association has to take part in this great battle. I wish all the best for this program. Commonwealth Medical Association has enacted a special subcommittee to ensure this program menace is controlled. Again, once again, it is a happy news for all of you. Dr. R.V. Asogan sir is chairing that session, chairing that committee of the elimination of the Stop TB or elimination of TB program on the Commonwealth countries. So he is not going to be an asset for India. He is going to be an asset for entire 56 Commonwealth countries. I thank you and thanks a lot for this opportunity and wish all the best for this program to succeed.
Thank you, Gela. Thank you so much.
Thank you so much, sir, for those wonderful words. Now we invite our own Honorary Finance Secretary, Dr. Piyush, to address us.
Thank you, sir. It is just heartening to see so many participants joining the program. It shows the commitment of IMA doctors for elimination of TB program. So my best wishes for this program. It will be a good program. Thank you.
Thank you so much, sir, for those wishes. Now we call upon our own Abul Hassan, sir, our JDN Chairman, National Chairman, to address us.
Thank you, Dr. Hariharan, respected leaders of IMA, Dr. Asagan, Dr. Dilip Banasali, sir, President, and all the leaders and my dear colleagues in JDN, Dr. Parul, Dr. Sil Joshi, and Indranil, Hari, Karan, and so many people. I welcome all of you. And it is a big meeting today, and also a very, very patriotic meeting today. And it's very heartwarming to see many of us are sharing our valuable time for the cause of eliminating tuberculosis from our country. It is really wonderful. I'm also happy that this message, this meeting has been passed on to JDN and MSN to conduct in such a bigger way. And I feel it should be, I also request Dr. Aswan sir to find out the structure of our INDTB program, including MSN JDN in the future also. I think it will definitely get a shot in the arm for our work, our association IMA's work towards eliminating or ending tuberculosis. And during my college, I always used to think that how will you eliminate this very deadly disease? But even after finishing my MBBS, I continue to see that so many people are falling ill and also dying because of tuberculosis. However, there are so much of advancements in treatment and also early diagnosis like expert MTB and TrueNat, RIF Ultra, and TrueNat are there so that it helps our society, getting the treatment and early and also curing. However, there are complications of MTB, tuberculosis with HIV infectious patients and also MDR TB patients. All will be definitely will be learning today more and more about these things. So I am very happy and also thank Dr. Asawan sir for initiating such a wonderful meet. And I hope all our boys and girls who are joined today and take it as a pledge to continuously attach themselves to NTB program organized by Indian Medical Association in years and years, in the future also. Thank you very much for the opportunity. Over to you, Dr. Hariharan.
Thank you so much, sir, for those wonderful words. Now we invite the MSN Chairman, Dr. Shalabh Gupta, to address us.
Gesh, is he there?
No, sir.
Okay. So we'll go on to the CME as such. I think all the leaders have addressed us, wished us. It is a great beginning by MSN JDN and to hear from the leader of this NTB initiative, our RV Ashokan sir, the role of IMA in the past and to the future. Let us hear from him.
Hariharan, first tell everyone whether this information of their registration so that they can be issued the certificates and the CPD points. What is the information you want to join, and whether we have already or are we streaming it in YouTube? Kindly tell us.
The YouTube's live is started. The live program is there on the YouTube currently. I think I'll be sharing this YouTube live link in this chat box as well. We will have the registration link for the certificate also shared in this chat box, so that in the next 2-3 minutes after you start, sir, I will share the link in the chat box.
So let this information be disseminated to everybody without any doubt.
Yes, sir.
Yogesh, kindly flash the presentation.
Okay, sir.
Now, when we go and look at what IMA can do in tuberculosis, I think this is the second slide. Go to the first slide. Yogesh, this is the second slide. Yeah. And before bringing you to a perspective
1 minute.
of, are you stuck? Yeah, go ahead. Before we go and look at it, what IMA can do, I think let us look at the gaps.
मैम
What
जैसे
are
होगा
the
मैं
gaps?
आपको कॉल करता हूँ बस 5 मिनट में.
Second slide is not coming. The global situation, I mean, the first slide. Yes. So this is the global situation where, we in 2015 formulated the SDG goals, Sustainable Development Goals, where it shows that 90% reduction in TB deaths and 80% reduction in TB incidence compared to 2015. You can see the graph. The red line in the graph is the target. And if this is going to be business as usual, the targets are going to be missed by a mile.
Dr. Sabari may be joining.
Yeah. Let me finish, then Sabari can answer. And the TB incidence as well as TB deaths, we need to do a loss. The next slide, Yogesh. Yogesh, go to the next slide.
Yes, sir.
Yeah. So look at this of our history. See, the current rate of decline is 2% per year. There are few countries which are declining by 4%, which is China and Cambodia. And our previous history shows that Europe and US in the 50s and 60s, and Europe after the Second World War, the incidence fell by say 17% and 10%. We need to fall. The decline has to be 20% to attain the elimination target. Elimination is 1 case per million. It's not eradication, it's elimination. Next. So we need to do more. We need to bend the curve. And if you can see very carefully, there are certain mechanisms by which we can bend the curve. One is the active case finding. Second is early diagnosis. The third is TB preventive treatment. Fourth is nutrition. And you may be aware, it has been recently published that around 20% of the cases can be prevented by just enhancing the nutrition, which itself is equal to vaccine. The fifth one is vaccine. A lot of development has happened in vaccine. Now look at all these 5 points. You cannot do all these 5 points without the profession getting involved in the right way. Next. Next slide, Yogesh. The real gap in TB is the funding. And you can see that TB care and prevention requires $22 billion globally. But what we have is 5.7. There is a lot of funding required to cover the gap in tuberculosis. Next slide. And the funding gap ultimately ends as the gap in the number of tests done. When we need a billion tests to be performed, we are somewhere around 281 millions, 28 millions tests. We are short of 2/3. And you can see the general funding gap is up to 55% in every nation. Fortunately, India, the domestic funding is 88% and 12% comes from global fund. It has been said by Indian Medical Association that even this 12% should be funded by the Indian government, and we should look for funding other nations to fill up this funding gap. Recently, United States has withdrawn 12% of the total fund of tuberculosis, whereas we want to have more. 12% of the entire global funding has been withdrawn by United States. Next slide. So this gap ultimately results in the gap in the notification. See, the funding gap results in the gap of the missing people who, the number of missing people is in millions. Next. The professional atmosphere is radically changing in that the new definition in tuberculosis, the entire dimension has been added, but WHO has now defined asymptomatic TB. So the number of people whom we need to reach out, find, diagnose has increased several fold. Next. And again, for the TB preventive treatment, we have a large gap. You can see the need and the gap is enormous. So all these issues involve the profession to step up its efforts. Next. So, what all I have narrated is the gaps in the global as well as the national TB care and control, what we need to do. There is a huge gap, and who is going to fill up this gap? And who else other than the National Medical Association and the association like Indian Medical Association, established in 1928, with around 4 lakh members, as JDN and MSN. This meeting is a proof that what all IMA can do will be from JDN and MSN. There is nothing that JDN and MSN cannot do in the future. So we need to reach out to in all the districts. We have the infrastructure, we have the reach out in almost all the 700 districts of the country. I think IMA should put itself in the forefront. Next. Next slide, Yogesh. Yogesh, are you hearing me?
Yes, sir. Yes, sir. Yes, sir.
Yeah. See, this is just a sample of what IMA could do between 2007 and 2015. We reached out through CME and trained around 1 lakh plus private doctors, and 4,000 plus doctors signed the MOU with the government. And in 1 year, IMA notified 1,12,000 TB patients. So that's the power of IMA that we can do it again. Next slide, please. So the NTB strategy is still more ambitious. We wish to reduce the incidence by 95% and reduce the death by 95%, reduce the incidence by 90%, no catastrophic expenditure. The Prime Minister had advanced it to 2025. We are nowhere, but our program recovered so well from the COVID shortage. There was 1 year of severe fall in the notification due to COVID, but we overshot our target after that. The program has done very well. Look at the next statistics. Yes. Now, there has been occasions when even the program said only 10% of the patients are from the private sector. Now, look at this. This study says that at least the minimum, if not more, 50% of the TB patients are in the private sector. So, there is a huge gap in the private sectors. If private doctors do not step in, we cannot fill up that gap. That's the elephant in the room as regarding the TB care and control work. Next. It will be very interesting to see. TB was not a notifiable disease. You look at this resolution passed by the Central Working Committee of IMA in 2012. We said that TB has to be a notifiable disease, and in 2012 itself, Government of India followed by notifying it. Next slide. These are only a couple of slides that I have. See, we have a role. We, the private doctors of this country, have a role to work with the government, because the early diagnosis, the counseling part of the patient counseling, the family counseling, and overall the responsibility of notification, stigma mitigation is a very important area where we can work, because the patient herself feels that she has been stigmatized, and with the family, the treatment adherence and the confidentiality. The most important thing is confidentiality. Why do 50% of people come to private doctors? It's because of the stigma and the confidentiality factor. Next, this is the last slide. So IMA has a huge role. First, it has a role of advocacy with the government to allot more funds, and also to have molecular diagnosis as the basic standard. It's no longer acceptable to have microscopy in any part of the country. It has to be 100%, nothing less. And the advocacy is also for the private doctors to fall in line with the standards of TB care. In standards of TB care, IMA is an inherent part of formulation and implementation, and it has the responsibility to update this knowledge. It's nothing but a revolution. The past 2 decades, what was the diagnosis? What was the treatment? It has went through a great shuffle. And then it's the international collaboration. The international collaboration with all countries. We need to be the leader. I close my initial introduction to all of you. I would request our Honorary Secretary General to address all of you. Is a great thanks from all of us. It was her foresight that we could actually collect 1,000 students here, 1,000 young doctors here, but it's also being streamed because of her permission. Welcome, Honorary Secretary General Dr. Sarvarinat. Kindly address the gathering.
Ma'am, please unmute yourself, ma'am.
Yogesh.
Yes, sir, she has to. She can, sir. She can
Please,
unmute herself.
kindly tell her. Ma'am, kindly unmute.
I've unmuted, but I cannot see myself.
Yes. Yeah, you are there. Kindly continue. We are all seeing you. We are all seeing you.
But I can't see any one
Go
of
ahead.
you.
Go ahead.
Anyway, thank you all, everybody who has joined in this meeting. It's a very important meeting, and I think from all the deliberation, those who are giving, they hear, and we can see some new things in the TB initiative, because as Dr. Ashokan has shows that we have to bend the curve. So we can bend. It depends on all of us. And if you all people, near about 1,000 participants, I'm really impressed, those who have joined. And if you just try to do what he says and follow what he says and try to do this, and it is nothing but the only thing we have to do here, that to prevent the MDR, multi-drug resistance, because the government is with us. It's a government project. They will give you free of cost the medicines, and we can arrange for the nutrition from somewhere, at least some of it. But so that is not a very important point. But the point is, usually what the patients do, they take medicine for say 3 months, 4 months, and then they stop. then the resistance develops. So how to counteract this resistance? That is the main thing, main problem to us, because our country has near about 1.6 billion, it may be more, I don't know, billion, and all the people who are suffering from tuberculosis, either first or second or in the third stage, whatever it can be, most of them are coming from the downtrodden people, the underprivileged people. So this is where the IMA can intervene. So please show us and all the young doctors by your very important and intelligent deliberation that what we can do to reach them, what IMA can do to reach them. And we want to wipe out this TB from the map of India, and as well as we want to do this resistant TB, we also want to prevent that. So please, thank you.
Thank you, ma'am, for those wonderful words. Thank you for all the supports that you have been giving to us. Thank you, Ashokan sir, for that wonderful talk on what IMA can do in the NTB initiative and where we stand. Next, we have our own leader, Dr. Shiv Joshi, who's the convener of IMA NTB initiative. He'll be talking on current public health updates on the tuberculosis. Over to you, Shiv Joshi.
Thank you, sir. I hope I'm audible. I'll be sharing my screen.
Shuki? Shuki?
Right. I hope my screen is visible. So hello everyone, I'm Dr. Shiv Joshi, and today we are going to discuss current public health updates regarding tuberculosis.
Shiv, you are not audible
Please.
properly.
Am I audible now, sir?
Yes, yes.
Yeah, much better.
Yeah. Thank you, sir. So we'll begin with the global situation, and we've seen that Dr. Ashokan in his presentation has already introduced us to the Sustainable Development Goals. If you look at the SDG of 2030, we see that there's a specific goal number 3, that talks about good health and well-being, within which we see tuberculosis targets in place. We see that 90% of reduction in tuberculosis deaths and 80% reduction in tuberculosis incidence rate compared to the baseline numbers of 2015 is what is anticipated. We also saw that these targets, though they are in place and we have been actively working to achieve them, from the recent Global TB report, we see that we are off the track. We saw this graph in the earlier presentation as well. But what I want to highlight here is, if you look at the global TB incidence rate, it has decreased, but the decrease is about 8%. However, what we were targeting for is about 50% reduction by 2025. And hence it is very far from those targets. Even when you look at the TB deaths, what was envisioned was at least 75% reduction by 2025, but we have only been able to achieve 23% as of 2023. Let's look at the global situation and see where India fits. If you look at the incident TB cases, so I want you to focus on the percent of global column here. And you can see that 1/4 of the global incident cases of TB, incident cases would mean new TB cases, are from India. 1/3 of deaths, that is the mortality of TB, happens in India. Multi-drug resistant TB is 1/4 of the entire globe in India. And we see that incidence within HIV, TB as a co-infection is about 6%, and mortality in HIV TB is about 5%. Incidence HIV TB might also be low in India due to overall distribution of HIV as a disease, which is more present in the African subcontinent. Let's look at India's commitment. It was on 13th March 2018 when our Honorable Prime Minister committed to end TB by 2025, which was 5 years ahead of the global SDG targets. And hence the vision for TB-free India is to, by 2025, reach 3 per lakh population in terms of mortality rate and 47 per lakh population in terms of the incidence rate. The baseline, if you can see in this graph and appreciate that the baseline incidence in 2015 was 237, and the latest global TB report in 2024 has shown that we have reached 195. That is about 16% decline, which is about twice the decline that you found globally. And when you look at the deaths, from 2015, we have reached to 22 per 1 lakh deaths, which is about 18% decline, which is a little less than what the global decline we saw. This is a similar presentation, but the graph is for India. And you see that the incidence was 237, and we need to reach 47 per 1 lakh. Here you can see my main focus here is on this orange arrow. It was in 2030 that the SDG has envisioned achieving the targets, but India has committed to achieve it earlier, 5 years earlier. And there's this orange arrow that is there on the timeline. We don't know in future in which year or when exactly we'll be able to reach this target. However, we do know that there need to be specific interventions in form of finding and treating all the persons with TB, in terms of early diagnosis, in terms of providing the TB preventive treatment, in terms of providing nutrition, and if and when we have a vaccine in place. I'll also tell in the upcoming slides about the ongoing vaccination initiative. We see that within the country's own national TB elimination program, there has been lots of research, innovations, and newer initiatives, which I would like to just briefly introduce to you here. One of the most important innovations or an initiative that has happened recently is launch of BPalM regimen for the drug-resistant tuberculosis. Drug-resistant tuberculosis usually has a very longer treatment duration, which can go up to 20 months. And BPalM regimen, it is also a beta-aculine containing regimen, brings this duration down to just 6 months. Again, this will be useful in terms of increased persons with TB, the compliance in increase for the treatment. It will also, it is likely to also lead to less number of loss to follow-up persons with TB. The second important innovation was launch of newer TPT regimen. This is again a shorter TB preventive treatment regimen. We find that what we have been traditionally using is 6 months of isoniazid, but recently 3 months of isoniazid plus rifampicin combination has been launched, which will be given in weekly doses. So you no longer have to take isoniazid daily for 6 months, about 180 days, but you can now shift to a lesser pill burden regimen of 3 HP. Also, similarly, for persons living in HIV, the regimen has been shifted to 1 HP. So instead of again taking 6 months of isoniazid, because they'll also be taking lots of drugs as part of their ART, this initiative has helped in terms of compliance as well as reducing the pill burden. Adult BCG vaccination study in partnership with ICMR. This has been launched in different states of India. And there have been specific groups identified, about 6 key populations that have been identified where this adult BCG vaccination has been done. And the study is still ongoing. We do not have the findings as of now to share, but we'll soon see the results from the study as well. We have this very important initiative called TB Mukt Gram Panchayat within the program. So in the program, it starts with declaring Gram Panchayats as TB free. There's, of course, an objective criteria of how do you declare the TB Mukt Gram Panchayat. But the idea is that there is a thought process to start from the grassroots level in terms of the elimination. There's also an attempt to increase the direct benefit transfer amount under the Nikshay Poshan Yojana from rupees 500 to 1,000, which is double the amount. This money is actually intended to support the nutrition of the person with TB. Also, there has been a launch of CYTB for TB infection testing. So more traditional tests that we were using for TB infection was tuberculin skin test. And wherever available, wherever facilities were available, we were using IgRA, interferon gamma release assay, for testing the TB infection. However, with TST, the challenge is that you need a repeat reading and there are multiple cutoffs which need to be interpreted. With IGRA, the challenge is the cost and also specialized equipments. So CyTB kind of is a middle ground where you have the antigens from IGRA in place, and the process, the way of administering the test is similar to TST. Hence, you save time in terms of upskilling the frontline health workers or the healthcare professionals who are already used to giving TST can also give CyTB as a test for TB infection. There have been a recent launch of national guidelines on differentiated TB care. This was launched just yesterday by Honorable Health Minister during the World TB Day function at New Delhi. There's also an accelerated effort to end TB in India, an extend TB study. This is again pioneered with ICMR support in about 35 districts as of now. To intensify the existing program strategies within this 35 districts by going very close to patient's house and treating the TB there, to intensify the screening procedures, to provide nutritional supplementation, to provide contact tracing and TB preventive treatments, as well as to engage Nikshay Mitras as part of the TB Mukt Bharat Abhiyan initiative, where people will come and adopt persons with TB in terms of supplementing their nutrition throughout the duration of treatment. Then there's this very interesting initiative in Tamil Nadu. We call it TNKT. And this was the first project in India that demonstrated the importance of differentiated TB care in terms of reducing TB mortality. This was a project done in 2022. And again, this was guided by National Institute of Epidemiology. We have the very important rations trial, which basically established the role of providing nutrition to the household contacts of the persons with TB, so that they do not break through into active case of TB disease. We have Pradhan Mantri TB Mukt Bharat Abhiyan, under which the concept of Nikshay Mitra exists, where persons will adopt the patients with TB and give them nutritional support. And very recently, there has been 100 days intensified TB campaign, which just ended a few days back. So this started on December 7, 2024. Again, by the hands of Honorable Health Minister, through Haryana, it was flagged. And the target of the 100 days intensified TB campaign was again to identify as much as those cases which we are not able to come across in our routine case finding efforts. Vulnerable population was targeted for this particular campaign. That included elderly more than 60 years, diabetics, alcoholics, smokers. We had people who had low BMI, less than 18.5, and similar categories were identified. And after line listing all of them, they were provided screening. All of the people who were asymptomatic but vulnerable were also provided X-rays during this campaign to identify even those people who might have TB but are not symptomatic. So these are some very interesting areas which the program has invested on. But this brings me to some key challenges, and towards the end of my presentation as well. We see that the third target, which we usually do not talk much about within the SDG, is about the reduction of catastrophic health expenditure to zero. We have seen that the estimated percent for this catastrophic health expenditure was more than 15%, and it has been showing an upward trends since 2000. If you look at the review of literature, you will find this number is anywhere between 7 to 32%. Now, the concern is that we do not have any nationwide cost survey that was done recently to give us the most updated values. However, some efforts are ongoing. Second important challenge is childhood TB. Because there are non-specific signs and symptoms, childhood TB is possibly bacillary in nature, and also the good quality sample collection is challenging because it involves children. There have been diagnostic delays. Treatment adherence is another issue that also HSG madam was pointing out. And a very, very important issue is stigma that is associated with TB, which actually prevents people from coming to the health facilities and get treated. There is also an issue with access to X-ray services. So in terms of improvement to this access, we see a great improvement. However, mobilization of population is a challenge, especially those people who are not symptomatic but vulnerable. For example, a person who is having a risk of developing TB, let's say a person with BMI less than 18.5, but does not have any symptoms of tuberculosis, it is very difficult to mobilize such individuals for X-ray services. You have extrapulmonary TB diagnosis, which was again indicated by Dr. Ashokan as well in his presentation. And we have a persistent challenge in detecting extrapulmonary TB because of one, the skill and expertise that is required for this diagnosis. Second, the sample collection. It is sometimes difficult to get extrapulmonary TB sample. And this also prevents in terms of, the patient does not get early diagnosis of drug resistance, because if the sample is not available, it delays the process for drug resistance testing as well, drug susceptibility testing as well. And hence, sometimes it also delays the initiation on appropriate regimen for the patient. We also have noted through the India TB report that there have been challenges in accessing care. So even when the treatment is free, the diagnosis is free, sometimes the challenges might be in terms of accessing care, and these challenges might not always be financial. These challenges can be geography based. These challenges can be around stigma as well, because let's say if there is a person with TB who wants to access care but is unable to go to their own city or own village, because they think if people will come to know, my life will be spoiled. If it's a young female, she might have concerns around her marriage, around her career. If there are people who are students, they might have fear of getting discriminated, and that's why also they will not access care. So this challenges in accessing care is not always financial or geographical or related to infrastructure, but it is also, in case of TB, a lot related to stigma. There is also a concern around inter-geography transfers, which affects the continuity of care, because it is possible, again guided by stigma or person's own preference for seeking care at a particular health facility. It is very much possible that a person living in place A goes to place B, where there is a doctor of his or her trust and confidence, and gets their treatment started there. But eventually they return back to their home place and sometimes lose access to that treatment. That is again a challenge where there is a lack of continuity of care. And last but not the least, for elderly having TB, there is challenge in accessing information, the right information, nutrition and care. This is mainly due to the societal and individual behavioral patterns. Now, when I look at these challenges, I also see opportunities. Opportunities for the junior doctors, for medical students to come up. Through this session, I or any of us, we do not intend to give you kind of a directive plan of how you want to engage. However, we want to serve this particular challenges to you and take them as opportunities and identify your place within this fight against TB. Can we do something about screening? Can we engage the youth of this country for reducing diagnostic delays, for increasing the treatment adherence for our persons with TB? Sky is even not the limit for the youth of this country, especially when it comes to JDN and MSN. So these challenges I present to you as opportunities, and find your place within the within this fight against TB. That's all from my end. Thank you. And I'd like to end with, yes, we can end TB. Commit, invest, and deliver. Thank you.
Thank you, Shiv Joshi. I think it was a wonderful talk and going through all the aspects and the recent developments in the public health domain. Thank you so much for the update. Next we have online is a talk by a microbiologist from Madurai, Dr. Malati Murugeshan. She is the lead microbiologist in Meenakshi Super Specialty Hospital. She'll be talking on recent advances in TB microbiology.
Thank you, sir. Am I audible?
Yes.
So good evening all. At the outset, I thank Dr. Ashokan sir, Dr. Abul Hassan sir, and Dr. Hariharan sir for giving me this opportunity, and the entire IMA-JDN team for having me here. Without much delay, I'll straight away move on to my topic. So it's recent advances in TB microbiology. I heard the audiences are mainly students and general practitioners. So TB microbiology starts with basics. So you may be feeling like you're sitting in a microbiology class, but I assure you that at the end of the talk, you'll be having some learning points to take away to your general practice. So evolution is always a history, and we know that right from the mankind or whatever products that we use, it constantly changes. The same way happens for the medical field, and we all know now, without any evidence or without any laboratory investigations, we don't start ATT and we don't start even antibiotics. The same way goes for TB diagnosis. Previously, maybe before 4 decades, there was only microscopy, which was there across all the centers, even in tertiary care centers. Now, the scenario has changed a lot. So we can see a lot of different ways of TB diagnosis, but always old is gold. The sputum smear microscopy still keeps to be there in the diagnostic algorithm by NTEP. So we have different ways of doing the diagnosis, but what is the right way? Are we missing any TB positivity, or we are misleading any sample to positivity needs to be considered. So that's why we use the word diagnostic stewardship. So that is, without diagnosis, there is no treatment. So in detail, in crisp or in short way, we'll see about each methodology. The first is sputum light microscopy. This was there right from when Robert Koch identified the TB. There is 130-year-old technique. The only problem with light microscopy is it needs more than 10⁴ organisms per ml. So if we do not collect a good quality sputum, we may be giving a false negative results. The other common problem with light microscopy is when we think about extrapulmonary. I think Dr. Shiv Joshi was talking and Dr. Ashokan sir was telling about the burden of extrapulmonary TB, where the diagnosis using the laboratory test is a bit difficult. So when we send CSF sample or pleural fluid sample, most of the time we get a negative report by smear microscopy, because the sensitivity is only 10 to 20%. So of course, if the sputum is collected in a proper way, and if you have a multibacillary load, then you get a very good sensitivity microscopy. Other cases, we do not have a good positivity rate with light microscopy. So when you send a sample for sputum to a microbiologist, we always report it in 2 ways. One is we say whether it is positive or negative, and also we give a grading. So it starts from 0 to 3+, 0 is negative, and for positive, we have 4 types of grading. This is based on NTEP. Initially, it was called RNTCP grading. So what is the purpose of this grading? One is to know the infectivity rate of the person, and next is to know after the treatment whether the grading is coming down or not. So we might know whether the person is having a response to a treatment or not. So this is very helpful in case of grading assessment. So then the evolution of microscopy happened. So there is something called fluorescent microscopy. You might have been seeing in your medical school and also in your laboratories. So for TB, there is a specific fluorescent that we use. It's called Oramin O-free fluorescence. So when we add fluorescent, because when a light microscopy, a microscopist or microbiologist is sitting and counting, they may be missing the bacilli because the staining technique is very, very important. So if fluorescent is added, it is easy to pick up, and a lot of computer tools has come up to count the fluorescents in it. So this is a very good sensitive test to pick up the TB bacilli. So because the fluorescent bulb is costly, so there is a lot of innovations that has come up. That is the LED fluorescence, which is cheaper and is being used in most of the diagnostic microbiology techniques dealing with the TB diagnosis, where it is having a very good sensitivity and also a specificity. But what is the problem with seeing a false negative? So most of the time what will happen, the clinician will think that it's a TB, but microbiologists will be giving a false negative smear report. But it's not only the problem with the technical errors, the most common problem is with the patient education. So whenever we say ask the patient to collect sputum sample, we can't just give one investigation to bring the sputum sample in a cup. It's very, very important to educate them, like how we educate, how many pills you have to take, how long you have to take. The same way, just take at least 5 more minutes to tell them how to collect the sputum sample. So it's very important that they have to collect 2 sputum samples, one at the spot sample that is called A sample, and the B sample should be at the next day morning. And they have to get up and then with a normal water, and then they have to expectorate the sputum. So other more important point is from infection control point of view, they should not expectorate the sputum in front of others because we are expecting a TB positive. So we have to educate them to go away from the crowded area in the TB collection room, or in home, they have to collect it in a well-ventilated area. So improper collection is a main reason for negative results. Other reasons are in the laboratory side, an improper way of heating or fixing the stains, or maybe a person who is not tuned to read the AFB smear may be giving the report. So these are all the ways we can avoid a false negative report. So that's about microscopic techniques. So then there are something called culture-based techniques. So previously, I think you all remember the word called Lowenstein-Jensen medium. So nowadays, this is not widely used across everywhere because it's time consuming. And once you send the culture, you will be getting the report after a month. By the time the ATT would have been started, or maybe it is not responding, so we may be losing the patients. We don't know whether it's really TB we are treating or not. So because of this time consuming, nowadays we are using something called liquid culture. So that is called MDR. So we say it is mycobacterial growth indicator tube. In short, we call MDR. So the main reason that we all use MDR is we get the results within 2 weeks time. Maximum is 2 weeks. Most of the time we get between 1 to 2 weeks time. It is a very good specificity, and sensitivity is 30 to 60%. As we see in microscopy, we need 10 power 4 bacilli per ml to show a positivity. But here, just 10 colony forming units. You get even the posibacillary, that is very minimum bacilli, TB bacilli will be picked up by the liquid culture. So this is very easy. Like once you give the sputum sample, there will be a preliminary process that is being done, and it will be put up in the tubes and it will be loaded in the machine. And automatically, when the bacteria, as you see in the left side, when the bacteria starts growing, it will consume all the oxygen. Once the oxygen is consumed, there will be a fluorescent that is being emitted. So once the fluorescent is emitted, the machine will beep a sound and we will be picking out as positive and we'll be reporting it. So it's very easy, less chance of aerosolization for TB for the laboratory personnel also. And this has also been helpful for the mycobacterial resistance detection in the other ways by adding the concerned ATT drugs. So I'm not going in detail, but we can remember that this is both helpful for phenotypic and also for the AST, that is ATT. So we know that there is microscopy techniques available and culture-based techniques available, but the game changer, that is in the evolution of TB diagnosis, the real game changer is the molecular method. We all know there is something called expert TB that is currently widely available across all the places in India, especially tertiary care centers, and even in the government sector, we have it in the even GH. So expert TB has become the revolutionary game changer. So we should know something about what it is and how to send samples for expert TB. And the next most molecular method that helped for managing MDR TB is line probe assay. I think Dr. Shiv talked about BPalM regimens. So to start those regimens, even to start levofloxacin, we should send line probe assay to see and confirm whether our first line drugs are resistant. And to start any second line injectables, we should send sample to line probe assay and confirm whether they are sensitive or not. So the first message I want to convey to all the general practitioners, please talk to your nearby tertiary care center, nearby government sector, and find where the LPA is available and have a networking with the TB division. And please send samples if you suspect a drug-resistant TB. So these are all the multiple techniques. I'm not going in detail, just to show the highlighted red color, highlighted yellow color, that is a reporting time. So if you send culture to us, it will take 2 weeks of time. Microscopy maybe 1 or 2 days, but we also can give the resistance within 1.5 hours. So the expert MTB, that is a gene expert turnaround time, is 2 hours. When we say turnaround time, it means once the sample receives to the lab and it has been loaded in the machine and the report can be given to 2 hours. But if we collect and ship, that shipping duration may differ, but it's the loading time to the reporting time. So if the expert machine is available in your facility, you can get the report within 2 to 3 hours of the running time. So this is the machine. So once the sputum sample is sent, a preliminary process will be done and will be loaded in the cartridge. So we have 4 cartridge machine, 8 cartridge machine. So once you load it, you just get a printed report and it will be given. So how the report looks? So this is a process. So the sputum is liquefied by activating a sample reagent and then loaded, and then you get a report like this. So there are 2 messages that we get out of this report. One is whether MTB is detected or not, and second one is whether rifampicin resistance is detected or not. So most common MDR TB in India is either isoniazid or rifampicin resistance. So even if we get one message like rifampicin resistance, we get the MDR TB detected and we can go ahead with the protocol for MDR TB. So the next most common question that we get from clinicians are, can they send samples for lymph node, CSF, for pleural fluid for expert? Of course, if you send sputum sample for expert TB, it's a very good sensitive and specific test. But there are other recommendations when you send for other samples. So let's take most common extrapulmonary TB that we get is lymph node. You're going to do a lymph node biopsy. The best test is to do a microscopy, to do a pathology, cytology in FNAC. Expert TB can be done, but if somebody is reporting negative expert TB doesn't mean doesn't ruling out lymph node TB. So please remember, it's only an additional test. It's not a confirmatory test for lymph node TB. The same holds for tuberculosis meningitis also, because the sensitivity is low. So always do imaging, correlate with your clinical features, look at your CSF cell count and keep expert TB as an additional test. In pleural TB, the pleural fluid and other fluids like peritoneal fluid are not a good sample for expert TB. So of course, the best is sputum. Other can be an adjunctive feature in addition to your clinical and imaging techniques. So moving on to drug resistance TB. So we have so many methods to detect the drug resistant TB. As we have discussed now, expert MTB RAF, then XDR method, TrueNat, which is widely used across India because of extensive use of TrueNat during COVID, and that has been converted into a platform for TB also. And we have line probe assay, solid culture and liquid culture. So again, I'm not going to talk in detail about each one. So just let us know. First is expert MTB, which helps you to find whether it is rifampicin resistance or not. Next is expert MTB XDR, there is ultra, which will give you the resistance for isoniazid, fluoroquinolones, ethionamide, and second line injectables. TrueNat also can give you rifampicin resistance. Line probe assay, you have first line agents line probe assay and second line agents line probe assay. You have to specifically give request for what you want. Solid culture we are not using, and liquid culture is also again time consuming. So let us look about the operational aspects. So now we know these methods exist like microscopy, culture, gene expert, line probe assay, and you are going to find out after this a very good program by IMA that where it is available in your place. But how to send samples? If you are a general practitioner, the first and foremost is talk to your nearby person, and you have to have your patient enrolled in Nikshay. So as sir mentioned, 50% of the people are getting treatment in private sector. We should not miss any patients in the enrollment onto the Nikshay portal. It's very important to track the patient and to be having the follow-up of the patient to take full course of ATT. So even if you are in the private sector, talk to your nearby government sector who is in charge of TB and get enroll the patient in Nikshay. And please educate the patient to give 2 specimens. If you do not have TB facility, TB diagnostic facility, whenever you are sending samples anywhere, always do a triple layer packaging and always send the sample in cold chain. Otherwise, you may be getting a false negative report. So this is the way you have to instruct the person to do a specimen collection. Just by looking the specimen, we can say whether it is sputum or saliva. Most of the time in microbiology lab, we see saliva samples, which is obviously going to give a false negative report. So please look at from the collecting point of view itself. If it is not a good quality sputum, reject the sample. Ask the person to give another sample. Do not transport the sample and waste the money and also the time. So that's humble advice from the microbiologist point of view to educate and get the right sample. So that's about sample collection and how to enroll in Nikshay and how to transport the sample to your nearby center. So there are a lot of diagnostic algorithms. Like for drug sensitive, we have a separate algorithm. For drug resistance, this is available in NTEP guidelines. So after the session, you can get my slides also. So I'm not going to talk about the algorithm. We have to just see what is needed to do the diagnosis. The one is smear examination, the another one is chest X-ray, and the third is CB-NAT. CB-NAT is nothing but gene expert. So to make somebody as confirmed case of TB, or to coin somebody as having MDR TB, we need only these 3. One is smear, another one is chest X-ray, and another one is CB-NAT. So smear and chest X-ray is widely available across every center, including the PHCs and near the GPs area. So only thing that we need is gene expert. So please, once you do a smear and get a report from the lab that it is a smear positive TB, always try to do gene expert to find whether it is rifampicin resistance or not. So now you know your patient is rifampicin resistant TB or sensitive TB, and based on that, you would have started the treatment. And after 1 or 2 months, you find there is no response. You feel it could be MDR or XDR, or maybe you want to shift over to some other drugs because you have allergic reactions or side effects because of isoniazid or rifampicin, or cross reactions because of other drugs. So in that case, instead of just randomly choosing another drug, always send for line probe assay and check whether the sensitivity for second line injectables and fluoroquinolones is available or not, and start the therapy accordingly. A few note about pediatric pulmonary tuberculosis. So we all know that it's very difficult to ask a child to give a good quality expectorate sputum. So in that case, we always do gastric lavage and other ways to do it, but still it's very difficult to get a sputum positive in pulmonary TB with pediatric, and also for HIV positive persons. So there are other methods like chest X-ray and skin test. So skin test is previously MAN2, and now I think we will talk about CY test, which is now been in practice for the past 1 year. So that's the best way to do the diagnosis of TB. So these are all the methods, and that's a diagnostic algorithm. So always start with 3 methods, which as per the algorithm. And also once you think of MDR and XDR, ask for the referral center and do appropriate diagnosis. A note about tuberculosis preventive therapy, which was again highlighted by Dr. Shiv. As we are not only thinking about treatment, we are thinking to go for the elimination, TB elimination stop or NTB strategy. Now we have to target those who are having latent TB also. So who are at risk of having an infection, latent infection, but not showing it, and who needs preventive therapy or close contact with TB patients. people who are having HIV, people who will start anti-TNF treatment, who are receiving dialysis, going for immunosuppression, and even I think healthcare workers, we need to actively screen. So this is the way, like you have a way to actively find out the TB and have a confirmed TB case, you start TB treatment. And if there is no signs and symptoms, you do the CY test or TST or quantiferon test and you find that they are having TB infection, then it's time we have to start the TB preventive therapy. So this started from last year. I think there was a GOI released from Government of India on, I think, April. So they started about Chi-TB, as already told by Dr. Shiv. The antigens that we use the same as that of quantiferon, ESAT6 and RF-CPP10. But the best thing is it is unaffected by the BCG vaccination status. Because when MAN2 is used, then we will be confused whether it's because of the vaccination or infection. But this next generation skin test is unaffected by BCG vaccination status, and it is very cheaper than quantiferon assay. This is same as that of our MAN2. So this is a kit which is available in India now. And it's the same as that of MAN2. You inject 0.1 ml, you read after 48 to 72 hours, and then in duration of more than 5 mm is considered as positive. And if they fit into the criteria for tuberculosis preventive therapy, then we can start the therapy, either 1 drug regimen or 2 drug regimen. So these are the widely used diagnostic modalities across India. But I think the world is moving to AI, and my topic is recent advances. So is there anything that helps in reducing the burden of humans? Yes, I think a lot of publication is coming up in utilizing AI to read the X-rays. So there are a lot of tuberculosis related studies that is coming up, and there's one good paper which correlated the use of AI in reading the X-rays, and they have compared across the world multiple studies. They retrospectively looked the human interpretation versus AI interpretation for X-rays, and it has given a very good correlation between human and AI. So maybe that will reduce the workload of human, but whether it's going to replace, it's of course always debatable, and I hope they won't replace microbiologists, because we have to look and see the cultures, and we have to look and see the smears. So I think we are irreplaceable. So, so to sum up, these are the 3 main methods that is used across, right from the resource poor to the resource-rich centers of TB diagnosis. There is smear microscopy, chest X-ray, and gene expert. So I'll end up with a quote by Mahatma Gandhi. Correct diagnosis is 3/4 the remedy. So without diagnosis, we cannot start ATT, and we cannot follow whether the ATT is working or not. So with this quote, I'll end up my talk. Thank you.
Thank you, Dr. Malati, for this wonderful talk. It was to the point. Next we have online is Dr. Parul. She is going to give us an update on the clinical end. So TB in clinical practice, latest update. Over to you, Dr. Parul, madam.
Thank you. I will share my presentation. Just a minute.
Parul is the head of the Department of Pulmonology in Government Medical College, Surat. She is a very, very active IMA leader, coming leader.
Are the slides visible?
Not yet, ma'am.
Okay, just a minute. Share it. Sir, are the slides visible?
Yeah, yes, ma'am. Yes, ma'am.
But actually, it is not in my control.
You can
Just a
make it
minute.
full screen, ma'am.
Yeah, yeah. Okay.
Yeah.
So, thank you. At the outside, I would like to thank our national president, sir, respected national president, sir, Dr. Bhanashali, sir, respected HSD madam, Dr. Shabari Datta ma'am, our national president-elect, sir, Dr. Anil Nayak, sir, from Gujarat, and our past president, Dr. Ashokan, sir, and Dr. Abul sir and Dr. Jalal and everybody, every past president and seniors, and of course entire team who have planned this CME very nicely and on a right time. So my job is to discuss about the updates in the clinical practice, and especially I have, as the policies have been discussed and microbiology has been discussed, I will limit to the treatment part majority of the times. So this is where I work, that is Government Medical College, Surat. And let us go just in brief about the newer classification of the TB. We all know, since long it is pulmonary TB and extra pulmonary, but now we defined it as bacteriologically confirmed or clinically diagnosed case. See what the guidelines say, or what the world says, that in majority of the cases, we should have the bacteriological diagnosis. Why? Because at one go and one point, at the starting point only, we want to identify whether it is definitely Mycobacterium tuberculosis, and my MTB is whether sensitive to the first line drugs or not, and whether it is sensitive to rifampicin and other drugs or not. So bacteriologically confirmed TB can be confirmed by either microscopy or CBNet, as discussed by madam in the previous slide, or it can be documented by liquid culture or solid culture. Though solid culture nowadays we are not using much, but yes, CBNAT we are using upfront. We want to diagnose majority of the cases of pulmonary TB by CBNAT, and it has very good sensitivity and specificity. So no case, I would say 95% of the case, 97% of the cases we want to diagnose bacteriologically, and rest of the clinical cases where we can't take the biopsy. For example, sometimes in eye tuberculosis, sometimes in brain tuberculosis, tuberculoma of brain, sometimes in cases of TB infertility where patient doesn't allow us to do laparoscopy. In such conditions only, we have to document it as clinically diagnosed TB. Otherwise, we should take all the efforts, whether this is pediatric TB, HIV tuberculosis, diabetes TB, we have to take all the efforts for diagnosing it bacteriologically by either taking sputum, either taking biopsy, either taking FNAC, or doing bronchoalveolar lavage of the patient, or taking some CT guided or MRI guided biopsy. So case definitions have now changed. There are two definitions only. This is a classification based on previously TB treatment, but we all know about it. So not going in detail, but the definitions just I will name. So new case if patient has taken less than 1 month, previously treated case, recurrent TB case, treatment after failure, loss to follow-up, and other previously treated patients and transfer in patients. So this is how we usually classify the patients of the in the clinical category according to the history of the patients. This has been already discussed, but yes, I would say that all newer tests are very, very important, and we should know which test to apply when. So already it has been discussed, and just one word, that CBNAT is most important and utilized upfront, and MGIT, liquid culture for AFB, is always a gold standard, and we have to utilize in especially in the extra pulmonary TB specimens. For example, paraspinal abscess, spine biopsy, joint tissues biopsy, we should subject the specimen for liquid culture for AFB to detect the live bacilli and to have the sensitivity of not only rifampicin. Liquid culture and sensitivity can give us the sensitivity of other drugs also, other first line and second line drug also. This already has been discussed about MGIT and other things. Diagnostic algorithm has already been discussed, but NAT is always very important and liquid culture is very important. Now let us go towards the prime, talk of our discussion of our talk, where this flowchart shows that if a patient is rifampicin sensitive, on the right side of the flowchart, if a patient has Mycobacterium tuberculosis and rifampicin resistant not detected, then patient is termed as sensitive tuberculosis, and the patient treatment is started as rifampicin sensitive TB, which is of 6 months. But now what is the difference in the treatment is it is daily treatment, and it is 2 HRZD plus 4 HER. Previously in continuation phase, we had only H and R, but now in continuation phase of 4 months, we have H, E and R. And above that, if a patient is having rifampicin sensitivity, still the patient's sputum is subjected to know that whether the sputum is isoniazid resistant or not. And according to the basis of isoniazid resistance, we decide the regimen for isoniazid resistance. So in short, we have four regimens. One is sensitive TB regimen. Second is isoniazid resistance mono H regimen. Third is the regimen which is on left side, which is for rifampicin resistance detected. And if patient is less than 14 years and there is no other drug resistance, and patient is not having non-lactating, non-pregnant, we will go in detail with for these regimens, but it is general idea I'm giving you. So in such cases, this is a recently launched regimen which is known as BPalM regimen, which contains bedaquiline, pratinamide, levoflox, and linezolid and moxifloxacin, has to be given for 6 to 9 months. And if the patient doesn't fit into this BPalM regimen, we can give either oral shorter regimen and longer regimen. So this algorithm is for overview how many regimens we have. DSTB regimen, the only difference is now that all regimens of tuberculosis are now injection-free regimen. All regimens are daily treatment, and in this also, in continuation phase, we have HER, which was not there previously. Previously it was only HNR, and we have made it in fixed dose combinations. So the number of pills have reduced, and we can see we have now different weight bands also. We have almost 5 weight bands starting from 25 to 75 kg. So according to that, the number of tablets are decided, and the number of pills in this regimen of sensitive tuberculosis has also reduced, and we cannot find now injection streptomycin, kanamycin or capromycin anywhere in any regimen of the tuberculosis. Role of corticosteroids is definitely there for TB, pericardial effusion, CNS tuberculosis, and ocular tuberculosis. 1 milligram per kg is the preferred dose, and we have to use it in patients. Second, now moving towards the resistant type of tuberculosis treatments, universal drug susceptibility testing is important, which means that even in private sector, the patient should be offered a chance for getting CBNet, which detects whether patient is rifampicin resistant or not. For first go, if patient is rifampicin sensitive, then also the test should be applied for checking whether it is isoniazid resistant or not. Further, sensitivity to quinolones like levofloxacin and moxifloxacin also should be tested once the rifampicin resistance is detected, so that it is known as universal drugs testing, which means we are not leaving the patient in between. If rifampicin resistance is there, we will check definitely the sensitivity of quinolones, and so that according to this resistant report, we can classify the patients. Let us go towards discussion of management of drug-resistant TB, which can be of different types. It can be either rifampicin-resistant tuberculosis. It can be H plus R resistance, that is MDR tuberculosis. It can be pre-XDR tuberculosis, means H plus R plus either quinolone or linezolid, or it can be XDR tuberculosis, means isoniazid plus rifampicin plus any of the quinolone plus either linezolid or bedaquiline. So these are the different drug-resistant tuberculosis for which we have the grouping of drugs. Grouping of drugs means group A drug, group B drug, and group C. We have to combine 4 to 5 new drugs to make a regimen for drug-resistant TB. Group A is a drug which has highest level of efficacy and least side effects. So levofloxacin or moxifloxacin, bedaquiline and linezolid, these are the group A drugs. We have highest level of efficacy, and we have seen almost treated 550 patients for bedaquiline and linezolid also. So we have seen that bedaquiline has wonderful result, linezolid also has wonderful result. But we have to be cautious in cardiac patients while treating with bedaquiline, and linezolid can cause definitely irreversible neuropathy and optic neuritis also. So these things we have to remember when we are administering these drugs. Group B drug is clofazimine and cycloserine or terazidone, but usually we use clofazimine and cycloserine. So usually what we do, we combine group A plus group B drugs for making a regimen for drug resistant TB. But if any of the drug of group A or group B is not available, or it has ADR, adverse drug reactions, or it is having resistance, then we can select any of the drug from group C for replacement, which includes ethambutol, delenamide. Especially we are using for delenamide, we are using these days for the pediatric MDR cases. Pyrazinamide we can use in group C, imipenem, celestine, amikacin, which is we are using the least, of course, not using ethionamide or prothionamide, which has lot of side effects as we have seen in previous years and past. So all these are our last priority to use. Our first priority is to use group A plus group B drugs. So let us, we just discuss about the bedaquiline, which is a very, very effective drug. It has high level of bactericidal and sterilizing activities, and it has to be given for 24 weeks, and it has a half-life of 5.5 months. So it's a very, very nice drug, very high level of efficacy when it is given in the regimen of BPalM. We have seen almost 95 to 96% success rate, as Surat also was one of the site for multi-centric trial for BPalM, and the results were wonderful for rifampicin resistant patients with pulmonary tuberculosis. Even extra pulmonary TB patients also have improved with this bedaquiline in the BPalM regimen. So let us come to that regimen. So treatment options for drug-resistant TB are: first option is 6 to 9 months of BPalM shorter oral regimen. Second is 9 to 11 months of shorter oral MDR regimen. Third is 18 to 20 months of longer oral MDR or XDR regimen. And fourth is 6 to 9 months of H-mono/poly-DRTB regimen. So if I talk of BPAL regimen, it includes bedaquiline, pretonamide, which is a new drug. Recently, we have started BPalM regimen in Gujarat, and of course, entire India has now started implementing BPalM regimen, which includes pretonamide, which we are using for the first time in the program also. So at present, bedaquiline pretonamide is not available in private sector. Linezolid is one of the drug which is we are using in BPalM regimen, and moxifloxacin also we are using in the BPalM regimen. Just to aware you that bedaquiline containing regimens have the cost of almost 14 to 16 lakhs per patient cost, and government is giving free of cost this treatment to the indicated patient who fits into the inclusion criteria of the BPalM regimen. So BPalM can be given to patients who are 14 years and above, who have less than 1 month intake of these second-line drugs, and who are not failing on the treatment. And also the patient should not be lactating and should not be pregnant. And if the patient is pregnant, the patient should be willing for the termination of the pregnancy. So these are certain inclusion criteria depending on the sensitivity, depending on the trials which have been done internationally. Exclusion criteria is opposite, but this type of BPalM regimen cannot be given to severe extrapulmonary TB diseases. It can be given to severe pulmonary diseases, and if patient has significant cardiac conduction abnormalities, it should be avoided. If QTC interval is more than 450 or more in males and 470 in females, it should be definitely avoided. Relative contraindications we are not discussing, but that we can read from the national guidelines. We have to be cautious when we are giving linezolid to the patient. As I've already discussed, that linezolid can cause myelosuppression also. Hemoglobin, platelet count, and neutrophil count can be decreased with linezolid, and it can also cause optic neuritis. And we have seen so many patients of irreversible peripheral neuropathy with linezolid, so we have to be cautious. We have to be cautious for liver enzymes. More than 3 times we have to stop. More than 3 times creatinine, more than 3 creatinine also we have to be cautious. And peripheral neuropathy of grade 3 or grade 4, we have to be cautious. So this is basically a 6 to 9 months regimen with 400 milligram daily dose for 1 to 2 weeks, and 3 to 26 weeks we have to give 200 milligram 3 times a week. Pretinomide 200 milligram daily, linezolid 600 milligram once daily, moxie 400 milligram once daily. So this is a regimen which is BPalM regimen. It has to be supplemented with pyridoxine too. Now coming to the second regimen, which is 9 to 11 months of shorter oral MDR or RRTB regimen. This is also not available in the private sector, but we can offer our treatment and diagnosis, free diagnosis by CBNAT liquid culture to our private patients also by referring them to the nearby PHC, CHC or DTC or tertiary hospital. Even private patients are also welcome in the government hospitals for diagnosis, free diagnosis by CBNAT and liquid culture also. And we are offering free treatment of this type of DRTB regimen to private patients also. So just in short about this regimen, that in this also rifampicin resistance detection is must, but patient can have INH resistance with INH A mutation and or only one mutation should be present. And in this category, fluoroquinolone resistance should not be present. If fluoroquinolone resistance is present, the patient will go to longer oral regimen, and patient should not have any extensive TB disease in this. Whereas in BPalM regimen, it can be given to pulmonary extensive TB, whereas in extrapulmonary extensive TB, we have to give longer oral regimen. So shorter oral regimen has some of the limitations, and in this ethionamide is now replaced by linezolid, and this is the regimen. We can see on the topmost part that it contains linezolid, levofloxacin, clofazimine, pyrazinamide, ethambutol, high-dose isoniazid, and bedaquiline, which is of 2 months, and bedaquiline for 6 to 9 months, 2 months of linezolid, and 4 to 6 months of levoclofa and pyrazinamide, followed by 5 months of levoclofazimine, pyrazinamide, and ethambutol. Need not to remember, we will share this I can share this presentation. Only thing which I want to tell you that in this also linezolid is introduced and clofazimine is there. In this cycloserine is not there. So this is a shorter regimen, and specifically a high dose isoniazid is used. Patient may develop neuropathy, but we have to be cautious for this. Now coming to this longer oral regimen, which is of 18 to 20 months. In this, we give bedaquiline for 6 to 9 months. This is the most important drug, I would say. Then linezolid is the second most important drug. Levofloxacin, clofazimine, and cycloserine. 6 to 9 months of bedaquiline followed by 18, means rest of the drugs to be given for 18 to 20 months. So in this case, if patient is H plus R plus Vilanol or linezolid resistance or bedaquiline resistance also. Very rare cases we are getting bedaquiline resistance also, and we have reported 2 to 3 cases of bedaquiline resistance also. In our multicentric trial of BPalM at our site, we also got one bedaquiline resistance patient. So don't think that bedaquiline resistance is not there, but it is not yet documented much. So if bedaquiline resistance is also there, then also we should document, and patient will be called as XDR tuberculosis, and for which we will replace the bedaquiline with the dalenomide. Dalenomide is a drug which will give replacement to bedaquiline. So in this case, we give 18 to 20 months regimen. We should have all second line drug sensitivity with us. We have to see which drugs we can replace. And in this case, we have to be cautious for the side effects of bedaquiline. As I have already discussed, cardiotoxicity, muscle toxicity, and arrhythmias, all these patients, we have to be cautious. In fact, we have made a ICU arrangement in our MDR ward, especially DRTB ward, where we have cardiac defibrillator, we have ventilators, we have monitors, just to monitor. When we started with the bedaquiline CAP trial before 5 years, today we have 550 patients, but in CAP trial, we were also scary whether this will cause some cardiac side effects. So we should have a small ICU for such patients who are very critical and getting all these drugs for longer time. Linezolid-induced optic neuritis is also not less common. We have reported almost 4 to 5 cases of linezolid-induced optic neuritis. So next regimen which I wanted to talk is isoniazid mono/poly drug resistant TB regimen, in which isoniazid resistance is seen. So in that case, we replace isoniazid with 6 to 9 months of levofloxacin. So the regimen becomes levo-REZ, and the duration is usually 6 months, but can be extended to 9 months. This can be given in patients of extensive TB with isoniazid resistance, uncontrolled morbidity, extrapulmonary TB tissues also, and it has to be extended to 9 months directly. It cannot have 1 month extensions. And again, if the patient first is negative and then first month, second month is negative and then converts to positive, we have to think for the other drug resistance. So if 5 months or later, patient will be called as treatment failed and has to be evaluated for other drug resistance. So these are the main 4 regimens of drug resistant TB. Drug sensitive TB differences we have already talked. This is something which is called, as madam has previously discussed, now we are doing CYTB test. And CYTB, basically on CYTB test and IGRA in the system, now the treatment is not only curative treatment, there is something called TB preventive treatment also. And in set society, we have already started under the leadership of district TB officers of different districts. We are giving TPT to reduce the incidence of new tuberculosis. And first we have to rule out active TB in this, and then we have to see whether the active TB is ruled out, then only we will start the patient on TPT. So in this TPT, it is for HIV patients. We have the adult and children more than 12 months, infant less than 12 months also we can give, and we can give 1 month of treatment. You can see in the slides, just a minute. You can give 6 months of isoniazid, and rest of the treatments also you can give, but TPT, you have to give 1 month of daily treatment, HN, isoniazid and rifampicin, you have to give for 1 month, or you can give 6 months of daily isoniazid for less than 13 years of age or pregnant or breastfeeding mother. In short, TPT has to be given in HIV patients, which is now compulsory. Again, TPT policy is for healthcare workers is also different. You can see the last column that 3 months of weekly 3 HP means isoniazid and rifampicin can be given, and 6 months of daily isoniazid also can be given. For the groups which are high-risk groups, contacts more than a year, close or household contacts below 5 years. So there are different classifications and groups for the TPT. But I mentioned here because now TPT is must, and TPT is already included in the program since last 2 years. And for the context of MDR and RRTB also, we have to give 6 months of levofloxacin daily for 6 months, and contact of isoniazid mono or polyresistant, we have to give 4 months of rifampicin daily regimen, and this is important part of the treatment. So not going into details of CYTB test, and as it has been already covered. So here I finish my talk, and I'm really thankful to all of you for patiently listening. And if any queries, we can take up. Thank you.
Ma'am, thank you so much, ma'am, for this wonderful talk. Next we have online is Dr. Subramaniam Swaminathan, Director of Infectious Disease from Langal Health City, Chennai. And he is going to deliver his talk on decoding the drug resistance and TB.
Good evening, everyone. Sorry, Hari, did I cut you off? I apologize.
No problem, sir.
Okay. So, can everybody see my screen?
Yes, sir. You can make it full screen.
Right, hold on. Okay, awesome. So, thank you. I've been listening to a lot of the talks that have gone on before me. And actually, most of the work that I am supposed to do has already been so beautifully covered. So I'm going to kind of change it and look at what are the practical challenges that we face and, everyday problems that we are likely to face in TB. This is not something that any of us have not seen. It's just that sometimes it's good for us to be resensitized about it. And on behalf of my society, which is the Clinical Infectious Disease Society of India, I'd like to congratulate IMA on pulling off such a beautiful seminar. And I think this is a very good step. It's something that we should all work towards strengthening. So these are my disclosures, not going to be relevant for today's talk. So again, this has been discussed ad nauseum. I'm not going to go into it. The old classification, something that we all grew up with, something that we all learned in medical school, and something that is very difficult for us to get out of our head, because without knowing this, there is no way you're going to pass your MBBS exam. And I think even today, there is some clarity in how we understand the drugs based on this. WHO has now classified this differently based on how we handle drug-resistant TB, especially when you have RIF-resistant TB, which is probably a marker for MDR TB. And therefore, the algorithm for choosing drugs is slightly different. So definitions, I think this has also been dealt with. I'm not going to go too much into it, so we know this. How big is the problem? India is ground zero for this. At least 1.25 lakh patients with MDR TB in our country. And I read recently today that they've done 10,000 sequences, whole genome sequencing, and about 7% of it is at least mono-resistant, scary numbers. And I think this is something we need to be paying a lot more attention for. How do we diagnose MDR TB? I think Dr. Malati Murugesan has gone through this very, very beautifully. The advances are amazing. But again, are we able to use these advances at the periphery, at the point of care? Now, that's where we need a little more innovation. Some of this is very expensive and some of this is a little temperamental. Using PCR is not necessarily that easy. Things like the expert MTB-RIF have made it much easier, but still there is a cost issue involved in it. And obviously you need follow-up cultures, you need liquid culture still as a gold standard. But overall, it's a lot different from when I started practice a couple of decades ago, when we still had only LJ-based cultures, and diagnosing MDR TB was an uphill task, forget treating. So let's talk about some clinical situations where we worry about MDR TB and how do we handle these kind of problems and what are the daily challenges that we face. So first one, these are all patients that I've seen over the last 20 years. So this is a lady from Kenya who had come to us with end-stage liver disease and underwent a liver transplant for unrelated reasons. Let's not go into that. 2016, she had a liver transplant. And her explant liver showed granulomas, which was very, very consistent with TB. So much that my pathologist had a look at it and said, Subra sir, this is TB. There is no question about it. Obviously, since we had it in formalin, there was no way to perform additional testing like Gene Expert. But then since she came from Kenya, where drug resistance is very low, we didn't worry too much about it and started on a first-line treatment. So we gave her isoniazid rifabutin because rifampicin cannot be given with the transplant medicines. We gave her isoniazid rifabutin and ethambutol, and the plan was to start pyrazinamide in 2 weeks' time because we don't want to start all of it together in a recent liver transplant patient. So, and then pyrazinamide was written down and started. She was discharged on ATT and immunosuppressants, and she reported feeling very well. Unfortunately, a month and a half later, things started going south. She started developing fever, cough, and hemoptysis and expectoration. What was the concern? So as you can see, compared to the pre-transplant X-ray, the post-transplant X-ray in the left upper lobe, you can see some infiltrates over there. And when we did a CT scan, it shows a nice cavitating lesion in the upper lobe. That's not the kind of patient we want to see in our OP, especially sitting next to our transplant patient, because that's an unmitigated disaster. But the question is, what is it? And remember, this patient has been given isoniazid, rifabutin, ethambutol, and pyrazinamide for the last month and a half. So the question is, what is it? And so are we dealing with some other concern, or is it MDR TB? So obviously these things came in, we did a sputum smear and we showed AFB, very much looking like tuberculosis. So what was happening? Are we dealing with MDR TB? How do you handle this? So fortunately, in today's day and age, we have molecular diagnostics, which can be done quickly. We immediately asked for a Gene Expert, we asked for a AFB culture and line probe assay. And the Gene Expert said, MTB detected, sure, high level, but rifampicin resistance not detected. Now, how does that happen? Well, answer is, it was very simple. She had not taken her ATT medicines. She had called her physician back in Kenya, who said, don't take new TB medicines with a new liver. It's likely to damage the liver. You don't have TB. I know everything. You stop the medicines. So she never took the TB medicines, and she ended up having disseminated TB with cavitating pulmonary TB. And, we followed up for all our liver transplant recipients for a significant period of time. We don't think anybody else contracted TB from her, thank God for that. But having said that, we don't always ask our patients about compliance. And I think that's a major Achilles heel. This becomes even more relevant in our MDR TB patients because one, compliance by itself is a risk factor for development of MDR TB. And in MDR TB patients, it's even more important to ensure compliance is being done. And therefore, we need to have, DOTS is a great way of ensuring compliance, having somebody supervise them. But I think it's also important for us to ask the patients, guys, are you taking your medicines? You know, if you have a rifampicin-based regimen, it's very easy. All you have to ask them is, what color was your urine? If it is as colorful as my kurta right now, you're probably okay. But if it wasn't as colorful as my kurta, then maybe you need to talk to them a little more. See, nobody wants to fall sick. Let's be honest about it. I have currently a young girl, a 16-year-old girl, who's lost a lot of weight, who we knew had TB. And in spite of 2 months of treatment, I'm wondering why she's not gaining TB. And then we find out that she's been taking the medicines from the parents, going to the bathroom and throwing it into the toilet and flushing it. So, you know, people not being compliant, and this is a very smart young girl, you know, she's a lovely girl otherwise. She was not happy with the medicine, so she was throwing it away. So the problem is that even with parent supervision, so quote unquote, they may not necessarily know what's happening. Sometimes you have to spend a little bit of time with the patient and start digging a little bit for you to know what's happening. So this is the first situation. Let's look at the next one. This is a 32-year-old gentleman, cough and fever for a month, significant weight loss and appetite loss. This happened a couple of months ago. No response to antibiotics. Otherwise, a very healthy guy, no prior medical issues. And what happened? His father was diagnosed with pulmonary TB last year. He took 6 months of proper ATT. The son was very clear about it. And then he developed symptoms 2 months after stopping therapy. And then he died 2 months later. So, you know, the whole thing sounds very fishy. He had a treatment card which said the gene expert was positive. So obviously it was TB. Unfortunately, he relapsed very quickly and then died very quickly after that. So the concern is there is something wrong as far as the TB is concerned. Are we dealing with the drug-resistant TB, which is maybe missed? It's a concern. So we did a sputum. We tried to get sputum in him, induce sputum and all that. Nothing happened. Finally, we had to do a BAL. And the BAL showed gene expert being detected and the rifampicin resistance was detected. So that shows that this is rifampicin resistance, which is probably a marker for multi-drug resistance. And we asked for the gene expert for the second line. And so lo and behold, you can see on the right side, it's resistant to INH as well. Fortunately, it's susceptible to all the other drugs. And of course, LPA is not an option. Dr. Malathi can correct me. Smear positive is where we should be doing a line probe assay. So we actually asked for a routine culture and the patient has been referred to the government center. I mean, the patient was counseled about it and he decided to go for the government center because he could get the BPalM regimen. Otherwise, I'd have to give him injectables. But again, this was a clear situation where there was a clear positive family contact with a probable MDR TB. And therefore, it is important for us to look a little harder and say, okay, this guy is a close contact of a probable MDR TB. Are we not missing probable drug-resistant TB? We should not be treating empirically in this kind of situation, and we should be testing a little more because the known contact of a probable MDR TB, risk of MDR is very, very high. So going back in time, nearly 20 years ago, this was when I just become a consultant. A 27-year-old gentleman from engineer from Guwahati, the wife had cradled his practically unconscious body on her lap for about 20 hours on a train to CMC Vellore. Had fever and weight loss starting in December of 2001, started on empiric ATT for 4 weeks, seemed to be a little better, but he still had fevers, was taking 4 drugs, very compliant. And then after 2 months, they reduced to 2 drugs because he developed dyspnea. They did an X-ray and they tapped the fluid. It was exudative effusion. So immediately said, you know what, this happens. Don't worry about it. We'll go back to 4 drugs. And then the effusion kind of settled. So they went back to, and then they were thinking about bringing it back to 2 drugs again. So when you have situations which are behaving unusual, you have to be careful. Are we missing something more over here? So he was stepped down to 2 drugs and it was going on for the next 4 months and he still had fever. That itself tells you there's something wrong. He had a new headache and then had a seizure and he was brought unconscious to Vellore. And imaging showed a large cerebellar lesion. And he had to undergo emergency craniectomy and the biopsy showed acid fast bacilli. Now, in this setting, you know it's probably drug-resistant TB because all of this is worsened in spite of good compliance to first-line ATT. And again, the surgeon managed to put everything in pickle. You know, they put it in formalin. You know, we often forget to tell our surgeons, guys, please give me a sample in saline because it's important. If you don't put it, if you put it in formalin, there is nothing the microbiologist can do to undo it because you kill the germs. I cannot do good quality testing after that. But fortunately, he was still on the ventilator when they had called me saying, do something. And I had asked for ET cultures. And remember, this was before the era of gene expert and line probe assay. And fortunately, ET cultures still grew MDR TB. Long story short, I did manage to see him about 6 years after this happened. And he was doing very well. We had to give him amikacin and whatnot. The guy did very well. He beat his TB and yeah, he's kind of deaf. But like his wife says, I'm okay with him being deaf. He's alive. That's all that matters. So I think so when you have a patient who's behaving weirdly and seeming to progress when you're on therapy, please think of drug-resistant TB. It is not okay. That is not the way patients behave. You should not be having persistent fever. I mean, if compliance is uncertain, then the next question is, are you missing a drug-resistant TB? That's very, very important. But not everything is drug-resistant TB. So let's look at this gentleman, 35-year-old insurance agent who I had seen in the outpatient. He had SLE with renal involvement, and he was started on cyclophosphamide, and he was doing quite well. This is before mycophenolate became standard of care. Everybody was getting cyclophosphamide. A lovely guy. He developed seizures, and then they do brain imaging, and they showed multiple ring-enhancing lesions in the brain, and the quantiferon gold was positive, and somebody said, oh, this has got to be TB, and they started him on ATT. I was not involved this far. So this is what happens. And he was started on ATT, and as you can see these worm-like stuff at the back of the head. And he was started on 4-drug therapy along with steroids. He starts improving. The fever remits. He's starting to eat well. His headache is better. All of that is good. And then he was switched to 2-drug therapy, INH and rifampicin. Of course, today that would not be acceptable. You'd have to give him INH, rifampicin, and ethambutol. But what happened was in March of the following year, about 3 months after starting this therapy, 4 months after starting therapy, he starts developing a sinus tract over here. And first, one node starts swelling up. It opens out, starts coming down as a cholestatic abscess, and it starts draining. They take a biopsy and a culture. They take a biopsy, and the biopsy shows tuberculosis. So somebody decides, let's start streptomycin. And then another one starts coming up. And that's when they thought, you know what, this doesn't sound right. Let's get somebody else to have a look at it. And long story short, the surgeon who did the biopsy, he knows me quite well. And he said, Subra, there's something wrong with this. Find out what it is. So they were once worried whether this could be drug-resistant TB. So what should we do? Should we ask for, should we just continue therapy? Should we worry about MDR TB? Or just ask for cultures and wait for it? Should we just start streptomycin and levofloxacin or delaminate and bedaquiline and whatnot? Or should we call ID? Well, long story short, the answer is always D, call ID. But having said that, not all of us have phone a friend option to an ID person. So how do we handle this? The first question is, how is the patient doing? This patient was actually quite well. In spite of the cholestatic abscess, he was continuing to gain weight. He was very functional. He was very happy. So this was an immune reconstitution-like syndrome, what we call paradoxical response. And if you want to treat this, you can treat this with a small dose of steroids. But by and large, this is more of a messy thing than anything else. How did we prove it? We actually got a biopsy, and the biopsy, I mean, he had already been started on all kinds of drugs, extra drugs, for possible drug-resistant TB by the time he had actually come to me. And we had did a biopsy and cultures, and the cultures didn't show anything at all. The cultures were all sterile, which basically means these were dead bacteria, and the host was just responding very well. Please keep in mind, he was on profound immunosuppression last year with cyclophosphamide and steroids, and therefore his immunity was very, very bad. Now his immune suppression is very low, and therefore he's attacking even the dead bacilli very well, and he's developed a severe immune reconstitution. I did see him 2 years after that, and he was doing very, very well. I have not had a need to see him after that, and I'm praying that he's continuing to do well. But this is an example of a mimic which may confuse you for drug-resistant TB, but it's not drug-resistant TB. And this is why it's important for us to do testing to find out if it's drug-resistant TB or not. Otherwise, we'll end up giving him unnecessary drugs. And this is a patient who's already high risk for nephrotoxicity. He's already got lupus with nephritis. You do not want to give him amikacin and things like that. You do not want to give him linezolid, bedaquiline, and pretominid and all that stuff, because that should be reserved for people who actually need it. Like it was put out, it is very expensive and it's a very precious resource. So it's important for us to make a diagnosis as to whether it's a mimic. So sometimes you can have a complication which sometimes looks like MDR TB, but it is not MDR TB, and therefore you should not go down that rabbit hole. So when do we suspect drug-resistant TB? So I would suspect drug-resistant TB if there is progression in spite of patients getting proper therapy. So if you have a patient who's on INH, rifampicin, ethambutol, pyrazinamide, based on a solid diagnosis, see, the way I explain to my team is 3 pillars. Is the diagnosis right? If your diagnosis is not solid, you can't go to the next pillar. The next pillar is the treatment. If your diagnosis is solid, are you giving the right treatment? If that pillar is solid, the next one is complications. You cannot jump to complications till the diagnosis is done. So always focus time and energy in making a proper diagnosis and ascertaining, if needed, if it is drug-resistant TB. So If a person is worsening in spite of therapy, it could be drug-resistant TB, or it could be some other diagnosis also. If there is relapse, especially when we were using non-ref regimens, but today even with ref regimens, sometimes we find relapse, like that a patient who had MDR TB whose father died of MDR TB. Again, we are now seeing more and more of MDR in the community as well. Not to the level that it's a nightmare, but to the level that it's scary. Non-adherence to therapy, and this is a very important Achilles heel. Those of us who worked in the HIV era, it is beaten into us that every time we see our HIV positive patients, we ask them, did you take all your medicine? Show me pill count and all that. Unfortunately, in TB, we rely on the family telling us whether that's happening. But I think we need to be a little more involved in that, in helping them understand the value of it, and also making sure that the medicine is being consumed. Inappropriate regimen, that was a major concern. People are still using regimens which don't make sense because they're scared of side effects and things like that. Sometimes my liver patients end up getting some really wacky therapy in the and like they may get moxifloxacin with ethambutol for 6 months, and they think that is TB treatment. That's not. That's just amusing yourself and not really doing anything useful for the patient, except probably getting him into more trouble with drug resistance. Inadequate dosing. Again, today it's much easier. It's a weight-based dosing, but please pay attention to that. You cannot give everybody the same dose. Improper duration. I cannot stress this enough. If you finish at least 80% and there has been a discontinuation and there is no drug resistance, it's probably okay. But duration is very important. And finally, like I said, a contact patient with multi-drug resistant TB. I'm not going to go too much into this. This was already discussed very beautifully by Dr. Parul. So what are the challenges that we face? Quickly there. So identifying MDR TB on time. Now, all of these points are very important. You have to identify it. You have to know if it is MDR TB, and it has to be done in real time. You cannot delay MDR TB because you end up having more people being affected by that. And also differentiating it from mimics, which look like MDR, but they're not MDR. So it's very important for that. So the second problem that I think is happening with MDR TB is now we are seeing more of extrapulmonary MDR. Lot of the diagnostics and the treatment regimens are all driven by pulmonary MDR. See, please understand that the government regimen is to make a better tomorrow. And therefore, they're focusing on MDR TB because that's important to cut transmission, which is absolutely fantastic. And we should do everything in our power to strengthen that. But unfortunately, this does not necessarily answer the problems for our patients who may have CNS TB or bone TB. And I've seen all of this. I've had CNS TB, I've had bone TB, I've had joint TB, I've had genitourinary TB, lymph nodal TB, obviously, and MDR, I mean. So MDR or pre-XDR TB. And treating those can be absolutely very, very difficult because there are very few guidelines, and giving them therapy for 1 year, 1.5 years and all that is mighty challenging. The role of steroids, thalidomide and infliximab, especially in CNS TB, is becoming more and more obvious. We are seeing more and more paradoxical responses, but that's only possible when you don't have MDR TB. When you have drug susceptible TB, it makes a difference to their life. Obviously, if you select the patients carefully. But how do we do all of this in the setting of MDR TB? How do we treat them for immune responses, which are actually more dangerous than the TB itself? We are also seeing rising quinolone resistance. In liver disease, that's a big problem because hepatologists love giving quinolones. They were using quinolones for prevention of SBP. Now, more and more data is saying that's actually a bad idea. And they use quinolones for all kinds of things. Today, anybody has a diarrhea, they get ciprofloxacin with tinidazole and things like that. And that is probably the worst thing that you can do, especially in patients who are high risk for developing TB, because you are increasing the probability of a quinolone resistant TB. And if it turns out to be MDR, you're in a big hole. Managing MDR TB in special situations is a particular concern. If you look at data from South Africa, probably one of the greatest risk factor for MDR TB is infection with HIV. And co-infection like this becomes even more difficult to treat because not only is the drug regimens more complicated, also that immune reconstitution and immune-based phenomena are going to be even more challenging to handle. And again, patients with liver disease, because most of these drugs go through the liver. So hepatologists are naturally very wary about using all these drugs, and very often they are uncomfortable using all the regimen, all the medicines that are required for this, and that ends up shortchanging the patient in terms of efficacy of the regimen. And this becomes sometimes a big problem because it does affect outcomes. And of course, like I said, very importantly, how do you manage the side effects of all these problems, especially with MDR TB, because the regimen is so complicated and so esoteric, and many people are still not conversant with the use of delaminate and protominate and bedaquiline, delaminate, protominate. These drugs, they are still not easily available for everybody to understand how it is. I think some amount of education and some amount of early identification and things like that are absolutely essential so that these drugs can be used very, very safely. And lastly, and I think this is absolutely important, this is true for all patients, for all conditions, and definitely for all TB patients, whether they are drug susceptible or drug resistant, managing compliance. Please talk to your patients. I know we talk to them, but very often we may not think about it when they come back for follow-up. At initial therapy, we tell them, guys, please make sure you take your medicines regularly. But sometimes we forget to ask them, have you taken all your medicines? And see, very often they are coming to us regularly as a surrogate marker for compliance. From the HIV data, we know that people who are not coming regularly for follow-up, very high non-compliance. But coming regularly for follow-up does not necessarily mean they are compliant. Please keep that in mind. You still have to talk to them and ask them, have you taken the medicines? Talk to the family, try and get other people involved and help them, express to you what their concerns are so that you can help them overcome that and take the medicines. And with that, probably we can all do better and hopefully see the end of TB. Thank you.
Thank you so much, sir, for the wonderful talk and putting it in very simple words. Thank you so much. I think just a reminder to all the participants, the form for the CPD points is there in the chat box, in the Zoom link, as well as in the YouTube live. So you can just fill it up. It will be left open for the next 20 minutes and then we close the forms. So please fill it up. And any comments from Ashokan sir before we ask the national president?
I am overwhelmed by the teamwork of my team. Well done, Hariharan. Well done, my team. And I am grateful for the Junior Doctors Network and the Emerson Network. They are coming together for empowering Indian Medical Association in the TB map of. I am grateful.
Thank you so much, sir. If any other leader has any other comments before we go to the vote of thanks. So, President, sir, can we go to the vote of thanks?
Yeah. I think 2 lines. I should really thank all the participants, the speakers, our past president, Dr. R.V. Ashokan, sir, for this wonderful webinar. I'm sure with this, everybody has enriched with the whole scenario of tuberculosis. Hearing all this, the latest things, what's been happening, the diagnosis and the treatment part of it, it's no doubt it's a big challenge to bring TB under control. But with all the support from the government and from the junior doctors and MSN who have been in the forefront to fight TB, I think we can end TB. Thank you very much.
I am grateful to the faculties. Such wonderful faculties. You could express yourself in real time. Yes. Such germane to the clinical practice. I am grateful to all of you. Thank you so much.
Thank you so much, sir. So all good things should come to a close today, and the fight to TB will continue. And thank you, MSN and JDN, for putting up this great show. And over to the official vote of thanks from our own convener of NTB initiative, Dr. Shiv Joshi.
Thank you, sir. And at the outset, I'd like to thank the leadership from IMA headquarters, our beloved President, Dr. Dilip sir, HSD Madam, Dr. Sarbri Datta, our very own immediate past President, as well as the Chairman of IMA NTB Initiative, Dr. R.V. Ashokan sir, our Finance Secretary, our Treasurer, Dr. Piyush Jain sir, and of course, the wonderful team from IMA-JDN, including the Chairman, Dr. K.M. Abul Hassan sir. Thank you for guiding and leading the team of IMA-JDN. Dr. Shalabh Gupta, sir, for leading the team of MSN. And all my dear friends, Dr. Jyoti, Dr. Indranil, Dr. Shankul from JDN, Arijit from MSN, Akshay from MSN. Thank you all for joining here. And I think expressing gratitude is one of the most important aspect whenever we plan and do something. And today's session would have been impossible without the presence of all my co-speakers, Dr. Malati, Dr. Subramanian, Dr. Parul Vadgama madam, for sharing their wonderful insights and beautiful presentations with us. I also want to thank at the outset Dr. Jailal sir, who has been instrumental in getting us the CPD points and has always been an unwavering support and a strong pillar for IMA activities, more so for JDN and MSN. Towards the end, again, not the least, the most important people of this event, the audience. I still see above 650 people online. It's over 10 p.m. now, but I appreciate the kind of commitment that MSN and JDN has given for this activity. And I'm sure that each one of us
Sure, there is one hand up. I think we should allow her. There is one hand up there. Just allow her. Let us hear what she has to say.
Sure, sir. Yes.
Yeah. Yogesh, kindly unmute her. Let us hear what she has to say.
So she is unmuted.
Go ahead.
Hello, sir.
Introduce yourself. Yeah.
Hello, sir, and everyone here. I am Bhavya Kumari I'm a medical student in abroad, like in Belarus, and my father is also diagnosed with TB. He went through treatment and he could not recover well. He is still suffering with his health issues. And being a student from Bihar and being far from my family, I'm always worried about him. He did not receive any proper treatment from the doctors. And since the condition of my village is not really good, we don't get proper information about these things. So I cannot explain my father because not everyone is well educated at my family. So that's why this conference was really beneficial for me, and the informations about the MDR TB, I think that I would like talk to the doctor who has been treating him about this thing. And I'm very thankful to all the faculty here for like having such kind of wonderful conference. Thank you so much, sir.
Yeah, you can contact Dr. Parul or Dr. Subramaniam. They are experts in the field. We provide you with their contact. Thank you for joining.
Thank you, sir. Thank you so much.
I think Ashokan sir, having that heard, that's the most important thing that we've heard today, and I'm glad that we could help with this particular initiative. In the end, actually, sir, it will not be fair if I don't say explicit thanks. Very hard work that has gone through the team of IMA-JDN and MSN, especially Indranil Deshmukh and his entire team of JDN, and also Arijit Akshay Yadav and their entire team of MSN, who have done tireless efforts to not just spread the message, but also ensure that we make the best out of this event. That's all. I formally close my vote of thanks here.
President, kindly close the meeting.
Yeah, we close the meeting with a hope that this time what we have spent is really useful, and the ultimate aim for which this meeting was conducted is useful to all of us to end TB. Thank you.
Thank you, sir. Good night.
Good night.
Thank you, sir.